Distributive justice and healthcare ethics. Today we are going to focus on distributive justice, which is one of the most practically important concepts in healthcare ethics. If there is one form of justice that clinicians, administrators, and policymakers encounter every day, it is this one. At its core, distributive justice asks a very simple but very uncomfortable question. When resources are limited, how do we decide who gets what? In an ideal world, everyone would receive the care they need when they need it. But healthcare does not operate in an ideal world. There are limited ICU beds, limited organs for transplant, limited staff, and sometimes limited medications or vaccines. Because scarcity is unavoidable, ethical decision-making becomes unavoidable as well. Distributive justice is concerned with the fair allocation of benefits and burdens. In healthcare, benefits might include access to treatment, life-saving technology, or preventative care. Burdens might include long wait times, higher costs, or the denial of certain treatments. The ethical challenge is determining which criteria are morally relevant when these decisions must be made. Importantly, distributive justice does not assume that fairness always means treating everyone exactly the same. Instead, it asks what kind of differences matter and why they matter. Let's walk through the major allocation criteria that are commonly discussed in healthcare ethics. The first is equality. An equality-based approach argues that everyone should receive the same share of resources. This principle is grounded in the idea that all persons have equal moral worth. No one life is more valuable than another. The strength of equality is its simplicity and transparency. It avoids favoritism, discrimination, and hidden value judgments. In some contexts, such as lotteries for scarce resources, equality is deliberately chosen because it is perceived as fair. However, equality also has serious limitations in healthcare. Treating everyone the same ignores differences in medical need and urgency. Giving an ICU bed to someone who is stable instead of someone who is critically ill may be equal, but it is not ethically persuasive. As a result, equality is rarely used alone in clinical decision-making, though it often serves as a moral baseline. The second criterion is need. Need-based allocation prioritizes those who are worst off. In healthcare, this usually means those who are most severely ill, most vulnerable, or most at risk of harm. This approach aligns closely with clinical intuition. Emergency rooms, triage systems, and disaster responses rely heavily on assessments of need. When someone's life is in immediate danger, most of us agree they should be treated first. The moral strength of this approach is its compassion. It takes suffering seriously and directs resources toward those who cannot wait. At the same time, need-based allocation raises difficult questions. How do we measure need objectively? Should resources be allocated to patients who are extremely ill if they are unlikely to recover? These tensions become especially visible in critical care settings. A third criterion is contribution. Contribution focuses on an individual's service to society. During public health crises, this reasoning is often used to prioritize healthcare workers, emergency responders, or essential personnel. The ethical logic here is reciprocity. Society has benefited from their service, and in return, society owes them protection so they can continue to serve others. While this approach can be socially practical, it is also ethically controversial. It risks implying that some lives are more valuable than others. It also raises difficult questions about how we define and measure contribution. Because of this, contribution-based reasoning is usually used narrowly and alongside other criteria. The fourth criterion is merit. Merit focuses on effort, responsibility, or behavior. In non-medical settings, merit-based allocation is common, for example, in scholarships or promotions. In healthcare, however, merit is ethically problematic. Judging whether patients deserve care based on lifestyle choices or past behavior risks moralizing illness. It also conflicts with core healthcare principles such as non-maleficence and respect for persons. As a result, merit plays a very limited role in healthcare ethics and is generally approached with caution. The final major criterion is ability to benefit. This approach prioritizes those who are most likely to benefit from a medical intervention. It focuses on prognosis, likelihood of recovery, and expected outcomes. The strength of this criterion is efficiency. When resources are scarce, allocating them where they will do the most good can maximize overall benefit. This reasoning is common in organ transplantation and ICU triage. However, ability to benefit raises serious equity concerns. It may disadvantage the elderly, individuals with disabilities, or those with chronic illness. Ethical practice requires careful safeguards to ensure that prognosis is not confused with social worth. In real healthcare settings, distributive justice rarely relies on a single principle. Instead, multiple criteria are balanced together. Consider ICU bed allocation. Clinicians often weigh severity of illness, likelihood of recovery, and immediate need. Or consider organ transplant waiting lists, which use complex systems combining urgency, time waiting, compatibility, and prognosis. Vaccine distribution during shortages similarly balances need, contribution, and public benefit. These examples illustrate that distributive justice is not abstract philosophy. It shapes life and death decisions every day. To conclude, distributive justice challenges us to think beyond individual patients and consider the ethical structure of healthcare systems. It forces us to confront scarcity honestly and justify our decisions transparently. Fair allocation does not mean easy allocation. Ethical healthcare requires acknowledging trade-offs, resisting bias, and committing to principles that respect both human dignity and practical realities. Distributive justice reminds us that how we allocate care is itself a moral act, one that reflects our deepest values as professionals and as a society.